name is Supriya Rao. I'm a gastroenterologist and obesity medicine specialist in the Boston area. You can find me on my Instagram. My handle is Gutsy Girl, GUTSYGIRL and you can find me there. I post a lot of content about GI, obesity, recipes, food. I'm really kind of into preventative medicine as well. And so, please, you can contact me, DM me with any questions. Can you just give me a quick background of your story and how old you are and like how everything kind of happened?
So I'm 36. And so maybe last September, I started, well, even before then, I was having a lot of fatigue. I mean, really, really, really fatigued. I noticed that I couldn't lift what I used to lift at the gym.
Sure.
Just didn't have any drive. And in September, I started bleeding. I went to the ER and they told me I was bleeding out of my anus, and they told me you have hemorrhoids.
Okay.
They sent me away, and fast forward until January, I bled really, really bad. I bled a lot. I bled so much that they kept me once I got to the ER because if I lost any more blood, I would need a transfusion. And so they checked everything. They did CT scans. They did check, blood tests, and nothing showed up. There were no cancer markers. CT scan didn't show anything. And I guess, you're doing GI, I guess that the cancer can hide in your colon. And so they were going to dismiss me, but I had a friend that passed in August from colon cancer.
Right.
He talked about he had to fight for a colonoscopy. And so when I asked them, they didn't have a problem. They said, we'll do it. It's going to be for your peace of mind because you're too young to have cancer. And that was it. That was the beginning of this fight, I guess.
Where was your cancer located?
It's in the transverse colon. They did a colon resection. They took out half of my colon, a little over half of my colon. They found it in 2 lymph nodes. So they're doing chemo now. We're going to do 6 months. And we're going from there.
I'm really glad that you advocated for yourself and pushed, because anytime someone has rectal bleeding, I automatically do a colonoscopy, because even though 95% of the time it's hemorrhoids, I'm not willing to take that 5% risk about what the more serious,
Right. And so that was the funny thing was that it's just, I had so many people say, "Oh, you don't have hemorrhoids. I mean, you don't have colon cancer. You don't have colon cancer.
Yeah.
You're too young."
Yeah.
And nobody actually physically checked.
Right. And statistically, that's true. As a younger, in your mid-30s, the likelihood of you having colon cancer is really low. But if you're symptomatic, do you have any family history of colon cancer? Like your parents, grandparents?
My grandmother passed from colon cancer about 8 years ago.
Okay.
For 7 years.
Was that on your dad's or mom's side?
My mom's side.
Did your mom ever have a colonoscopy?
Yes, she's had polyps since she was 28, I think.
Right. So the fact that she had polyps at such a young age, and continued to have polyps moving forward, would have been kind of like a signal to a gastroenterologist to say, oh, okay, you're having polyps this young. Your mother had colon cancer. Make sure that your family members also get, your blood relatives also get colonoscopies.
I think that's the disconnect that we have is that, when she did it, might have, she's 60, so that might have been 30 something years ago.
Yeah. They probably weren't thinking about that necessarily at that time.
Right. And I think, I hate to say it, but even now, they probably don't think about it even now, hey,
maybe.
Let's.
Yeah.
And so they're just dealing with that. It was a little tough. When I first got the resection, knowing what to eat, what upset my stomach, what didn't was really hard. I got used to it, and then boom, started chemo. And started all over again because I guess this is the flora that's diminished because it kills pretty much all the cancer cells. I mean, all of your colon cells, right?
Right. It's really tough because having a bowel surgery is a major surgery. And so just recovering from that takes time, and getting your bowel habits under control and making sure that your gut flora kind of comes back to what it was. How soon after surgery did you start chemo?
I think it was 2 months.
Tough.
So what do you suggest usually? I mean, normally, what do you think? Because I guess it's a case by case basis. And so
Right.
I guess we should really talk about colonoscopies in general.
Right.
What do you suggest as far as people that either have a history or they've had complications? Because most people go to their physician and they might be given Imodium or, because the GI symptoms don't stay. Like my symptoms didn't stay. They went and came. So I didn't bleed constantly.
Right. Anytime someone has rectal bleeding, I always say, the first step is talking to your primary care physician, always, just to discuss it. Oftentimes they'll do a rectal exam. They may say hemorrhoids, try something. And like, you kind of have to look at the demographic as well. But for me, and my primary care physician referrals are pretty good about this. If they see rectal bleeding, they almost automatically send the referral to me so that I see the patient and talk to them and get a sense of like their family history. Do they have a family history of colon cancer, a family history of polyps? We talk about colonoscopy. Obviously, if they're like 20 years old, I don't necessarily push it on them unless, they start having a little bit more persistent, like more than a week's worth of bleeding or something like that.
I mean, even then, let's just say you're 20 something. There's no harm in a colonoscopy, right? Because I think a lot of people
colonoscopies are very low risk. I think in general, people don't get them because they seem super invasive. And obviously it's not a place you want people up all in, you know what I mean? It's not like,
Right.
you want someone doing a rectal exam and putting a scope up your bottom and stuff like that. I think that really freaks people out a lot. And I get it. And so that's why I do a lot of colonoscopy education when I'm in to visit with them. I discuss what it is. We use a medication called propofol to, put our patients to sleep. It's really great. Quick on, quick off. You're basically taking just like a really deep nap.
I mean, I don't remember anything from mine.
Yeah.
I mean, I remember we counted down for a while and we said something and then boom, I'm gone. So I mean, I didn't have any pain or anything afterwards. So
yeah, of course. Colonoscopy is rarely painful. And so during that nap, you're not aware. I think maybe 10, 15 years ago, different kinds of medications were being used for sedation and people may have woken up during their colonoscopy and weren't adequately sedated. But now the medications we have are much better. And colon cancer is the #2 cancer killer in this country. They're expected to be like 150,000 new diagnoses of colon cancer. So like in terms of diagnosis, it's number 4 or 5 after like lung, breast, and prostate. But in terms of killing patients, it's number 2 because people are really nervous about getting colonoscopies. I mean, they just don't think it's, I feel fine. I don't have any symptoms. That's why I shouldn't have one. But this is the only modality which actually reduces death and reduces mortality for this particular disease. It's a really important screening test. And it's also a really important diagnostic test. This is the only test that allows the physician to look inside, look, if there's a polyp, if there's some type of abnormality, and actually do something about it. There are people who do stool testing, Cologuard, FIT testing, all these different like kind of stool test modalities, but they don't come close to colonoscopy in terms of being as good a test to actually do something about.
And that was one of the things that someone brought to my attention. Is I forgot the name of it already, but it's the one where you mail it in. Is it Cologuard?
Cologuard, yep.
Is it looking for CEA, the cancer markers, or what is it looking for?
So it looks for certain like DNA type markers that would be more like polyps. And so the problem is that the Cologuard is not a super sensitive test and it actually misses quite a few, it misses polyps for sure. It has like, I think a 12 to 15% miss rate on cancer. So it's really not a great test right now.
And even then, if you did the test,
and it's positive, you have to get a colonoscopy anyway.
You got a colonoscopy anyway. And I think, and that's why I tell a lot of people and a lot of friends, they're kind of scared because, I can just send it in and get the stool test, or they can just test me for this. I said, well, if it does show up, you still got to go in. If you get the colonoscopy, they can go ahead and, if it's not cancer, or even if it's cancerous, they can snip it right there on the spot.
Exactly.
And
we do it in real time. And, I have to say that like I've had negative Cologuards and found polyps. I've had positive Cologuards and then they end up coming to me. And because Cologuard is considered a screening test, insurance only pays for one screening test. So the insurance will cover the Cologuard, but then when they come for their colonoscopy, they end up having to pay some amount out of pocket because insurance isn't covering the colonoscopy. Whereas if they had just come for the colonoscopy in the first place, it would have been fully covered.
So what do you think, in your opinion, and I know it's hard, it's like trying to save the world. What do you think would be the best method to increase screening, colonoscopy screenings? I mean, and even at the very least, decrease the age, because the age for screening is so high. Right?
So currently, actually the American Cancer Society, I believe last year, recommended a decreased screening age to 45 for colon cancer, because right now the GI societies are still saying 50, but I think hopefully in the next year or two, that will also decrease. It's a 50 for, general population, but then 45 for African Americans actually. But I do believe that we should start at 45 just because just from my own personal experience, I'm seeing a lot of rectal cancers in younger patients. In their early 40s, I'm seeing a lot of rectal cancer.
I was told, because I questioned, with my primary care physician, and I'm not putting him saying that he's at fault at all, but
right.
I asked him, he said, with my grandmother passing at that age, he would suggest starting at 40, but I'm 36. And so if I'd waited till I was 40, I'm positive it would have been stage 4.
Oh, for sure. Yeah. I think the thing is that your mother had a colonoscopy at the age of 28 and had polyps. So for me, that kind of speaks to when you probably should have had screening done, maybe at 30 around, what I'm saying?
Even talking to other people, everybody said, oh, well, she didn't have cancer. I said, well, she had polyps. It's like, oh, that's not cancer. I'm like, but
that's true. And what they're saying is true, but she had her mother who had a colon cancer, and she herself had polyps in her 20s. So to me, that speaks as to something, maybe some type of familial thing going on. How about your maternal aunts and uncles? Did any of them have colonoscopies with findings?
No.
Okay.
But that was another thing is, when I was first diagnosed, they told me when they did the pathology report, it tested positive for the Lynch mutation.
Oh, it was positive for Lynch.
But when I did the genetic testing, they couldn't find any links to Lynch.
That's so interesting. Wow.
I'm actually on my YouTube channel. There's a video with my Lynch diagnosis. And with that, I recorded it with my genetic counselor.
Yep.
And so I recorded that whole conversation. And it was just strange because, I just knew that was the answer. Okay, that makes sense.
Makes sense, yeah.
And then nothing showed up. And I wonder, is it just another, mutation that they haven't discovered yet? Because
that's totally possible. That is totally possible.
So what do you think? What do you think the best, other than the 45-year-old age, how do we catch this earlier for people that, are at risk? That
I think we just need to be really good about documenting family history. The primary cares and gastroenterologists, just need to be really good about truly finding out whether or not somebody has a family history of colon cancer.
Well, that's secondary. That's secondary, and that's after you had those symptoms. But I think us as the ones with the highest, risk or the highest thing at stake, we need to know how, as a civilian, we need to know how to document those things. We need to know how to ask those questions, and communicate that, that history or, even no symptoms. And I think a lot of those, because if it never gets to the doctor if we never have any problems.
Right. I think, it's hard to have a screening test for patients in their 20s and 30s when the vast majority is over a certain age. I think that, just being really mindful about what your symptoms are and, what changes in bowel habits, even a little bit of bleeding in the stool, any changes in weight. I think people need to be really cognizant of those kinds of things and report.
That was one of my things, is that I always looked at my stool and I didn't have a change in bowel habits until almost a month or two before my diagnosis.
Right.
And I didn't see any blood until, that September. And so before then I always looked. Yeah. Because it's your bowel is very important and it tells you
of course.
a lot. Yep. And I just didn't have those symptoms. And that's what the GI doctor that found it, he said, you're really blessed because they normally don't bleed the way they did. Mine bled a whole lot.
Yeah, I'm glad you got the colonoscopy. Yeah.
He said it usually doesn't bleed that much, not that early on.
Right, until later stage, honestly.
Right.
Yeah.
So what do you think? I mean, what would you tell a person that's, 30, 25, what do they need to look out for? What's important?
Yeah, I mean, again, like it's hard because a lot of the symptoms don't come until we're getting into kind of more advanced stages, but it's just really knowing your body, any sort of weight changes, any even mild change. Like if you're regular your entire life and all of a sudden you don't, and there's no reason for it, like it's not like you had an infection or something like that. There is a change in bowel habits. You're nauseated, you have kind of aversions to food, bloating, all of these things, I feel like you need to be at least brought up to your primary care and then explored to see
So
if it's.
bloating is a huge symptom for that.
It can be. I mean, it can be a sign. It's not specific to colon cancer. It can be a sign of different things. It can be a sign of just IBS. It can be a sign of inflammatory bowel disease. It can be a marker for a lot of different things. But if you have like continued bloating, you should definitely talk to your physicians about it.
And so with IBS, does it put you at an increased risk, or does Crohn's put you at an increased risk for colon cancer? I've seen things.
Right. So IBS is irritable bowel. So irritable bowel doesn't put you at an increased risk for colon cancer. Irritable bowel is basically just alteration in bowel movements with pain. It's kind of like a brain gut issue, honestly. It's like, the nerve endings in your GI tract just aren't working so great and they're causing pain and changes in bowel habits. When you do a colonoscopy, everything looks normal, but functionally you feel bad. So that doesn't have an increased risk of colon cancer, but Crohn's and ulcerative colitis, which is inflammatory bowel disease or IBD, puts you at an increased risk for colon cancer.
So for them, their screening should be earlier anyway, which is probably is.
Yep, because they're already getting colonoscopies anyway for looking at their disease activity in the colon. So,
but even then, their frequency for their colonoscopies, especially if it's not a very chronic, or it hurts a lot, or if it's a very asymptomatic, the screening isn't that high even for those though, right?
So basically, if you have ulcerative colitis or Crohn's colitis, so Crohn's disease can affect any part of the GI tract, like the small intestine, but ulcerative colitis is only in the colon. So if you have ulcerative colitis or Crohn's that's in the colon, and even if you're under complete control and everything is going really well on the medication that you're at, about 8 years after your diagnosis, you need to start having colonoscopies every 1 to 2 years because of your increased risk of colon cancer.
Okay, so if after 8 years, every 1 to 2 years, you need to get it. And I think that's something a lot of people aren't told, because either the physician's busy or the physician just didn't know, or something happens, or they might have forgotten. So I think that's huge. I have quite a few friends that have ulcerative I can't say it.
Ulcerative colitis, yeah.
Colitis, or I've got a friend that has Crohn's, and really bad Crohn's actually, and so I don't think they want to do the colonoscopies on them as much, but they need to start at a certain age, or at a certain
after a certain time after their diagnosis. Yeah.
Okay.
Yeah.
All right. Well, I really appreciate everything. Is there anything else you want to add?
No, I just think that I think people just need to understand that colonoscopy is a really safe screening test. Obviously, with any procedure, there's a risk, but it's really small risk. It's like a risk of 1 in 10,000 of causing bleeding or, tear or infection. So it's like a very low risk procedure for something that can reduce the number of deaths attributed to colon cancer. And so, I feel like about 1/3 of the patients who should be screened for colon cancer don't get it purely based on this fear, or they feel like I don't need this, or they don't want to see a doctor. That's almost 25 million people in the US who don't get colonoscopy because of some reason. And those, we could say, and if there are colon cancers in any of those, that's an automatic life-saving procedure for them. And so I think it's just really important for people to know that.
At the same time, I think some physicians, let's just say your family practice physician, they're not as well informed as well, especially if they've practiced, 30 or 40 years. That information is outdated. And I mean, I know people, you get updates, but sometimes the information doesn't get relayed.
That's true. So it's just good to stay up to date on all of these things. The guidelines, they're done every couple of years, but as of right now, the GI Society say screening should start at 50 for the general public, 45 for African Americans. The Cancer Society say 45 for the general public. I do imagine as the next few years go on, hopefully we'll reduce that to 45 for everybody.
Yeah, hopefully I'll be honest, hopefully 40. I think 40 is a better number. But I think,
They're constantly being revised, so who knows
I
what it will
don't
end up
want to be
being.
political, but I think it's more of an insurance thing too, because insurance companies don't want to pay for something. If it's only 2% that might have it, they'd
Right.
rather just
Yeah, of course. Yeah, definitely.
they'd rather just pay to heal the 2% that get cancer than pay for the 98% because it's cheaper. And it's a sad fact, but I guess the more people that get cancer, or the better those numbers get, the easier it is. So what would you say for someone that doesn't have insurance?
So I live in this, right. I mean, I live in Massachusetts, and so anybody can sign up for Mass Health, and Mass Health, it's kind of like Obamacare essentially. And colonoscopies basically covered under that provision. I don't
really
know individual states what they have, but.
Okay, I really appreciate it. We'll do another meeting for the nutrition.
Nutrition, yes.
But I appreciate everything.